Hi, my name's Kevin.
I'm Rifka.
Do you want to spin?
Yeah, so this is a case study about a 72-year-old man who came in with heartburn, nausea, and an inability to eat.
So our patient's symptoms were quite innocuous at first, with the majority of symptoms being right here, mild chronic reflux. But as time went on, his life became quite a nightmare. At first, he started having an inability to eat any solid foods, as every time he ate, he would have progressive nausea, or at least satiation, which means simply he would eat a small amount and feel completely full, and he would have heartburn. This would make it near impossible to eat anything, as he would have a striking pain, is what he noted in his esophagus. And this led him to resort to blending his foods in order to eat. And at this point, he thought it would end the agony. He thought it would be a good idea to get a gastroenterology evaluation. But the prognosis was quite poor. He had an EGD, which is basically an endoscopic view of the stomach, as you can see in the figure over there, where they have a little probe with a camera to try to see if there's any visible lesions or hypodensities that may be indicative of a certain infiltrated disease. But in his case, there was so much food in his stomach that they literally could not see anything. And so they also tried a scintigraphy, which is, as you see in that figure right there, they use a radio tracer to see how much food has passed through the duodenum and into the small intestines over time by seeing how much food is being pulverized. And as you can see over there in that figure, it's supposed to, that black mark is supposed to degrade over time and become faint, indicating that the food has been pulverized. But in his case, the most normal people had about 10% of food left after about 8 hours after maybe an applied diuretic. He had 80%, which means he was so clogged up that his stomach could literally not pass the food to the intestines. And after this, they decided to diagnose him with idiopathic, which means unknown, gastroparesis. They had no clue as to what the source of his stomach problems were, and they just arbitrarily said, for now, it's gastroparesis. They gave him certain medications for acid reflux, and it didn't do anything. And after 2 months, he went from not being able to eat blended foods to having to resort to only eating liquids, like powdered protein shakes and stuff. And it got to a point where his condition was so chronic and bad, he couldn't even drink liquids. At this point, he was admitted to the ER.
Yeah, so as Kevin said, once he was unable to process liquids, he was admitted to the ER. He had no notable reported illness in that past year, other than pretty notable weight loss, about 14 kilograms in the year. CT scans were taken of the stomach, the abdomen, the pelvis, and the chest. The only ones that we have images for are of the abdomen. In panel A, where the arrow is pointing, that points to thickening, gastric wall thickening of the antrum. Panel B points to more gastric wall thickening of a part of the stomach right towards the extension to the duodenum, called the incisura. And panel C, all of them really show, but panel C in particular shows a stomach distension. And upon examination, the blood test was normal, nothing seemed notably out of range, and there was no palpable lymphadenopathy, which it will be notable later down the line. There were, however, hepatic hypodensities, meaning lesions that were noticed on the liver. And we'll talk more about the esophagus later, but there was some findings there.
All right.
How old is this guy again?
72.
Oh, okay. Yeah.
So the patient had 4 key symptoms, being reflux, heartburn, food intolerance, and satiation. And the bulk of these symptoms come from 3 main sources. First of which is he had a compromised reflux barrier. Due to the wall thickening in his stomach, there's little fibers that prevent the acid from going up through the esophagus, but because of that wall thickening, it kind of distorted and prevented the function of these fibers, and this would lead to, obviously, his reflux. And then the other 2 key symptoms, delayed gastric emptying. What this means is the stomach has to pulverize the food in order to pass it through the duodenum into the intestines. However, in his case, for whatever reason, the stomach could not do that, and this would lead to the food being built up and clogging his stomach. And more importantly, he also had delayed accommodation. The stomach, as food goes in, has to make a spot or reservoir for that way the barrel receptors going through the stomach do like a synapse at the brain that, oh, I'm full. But in his case, any sort of food would go into the wrong spot, and this would increase the pressure and tell the brain, yeah, I'm good, like don't eat anything else. So that explains why he had the food and early satiation, and the gastric emptying explains why he had the food intolerance, as he was so clogged he could no longer accept any for solids, and he couldn't accept blended foods. And important to note, like for gastric emptying, usually the liquids are passive, so as long as like it's not completely blocked, like you see in that figure, the liquid should pass through like unimpeded. In the differential diagnosis, the first key disease that they thought it could be would be gastroparesis because of the effects that they saw in the scintigraphy. But there were 3 reasons why they were so keen on saying it's this. First of which is his severity progression was just too fast. In the matter of a couple months, he just went from not being able to eat any solids to literally not being able to eat liquids. And more importantly, his hemoglobin was quite mild. Gastroparesis is a hyperglycemic, which is a condition which means there's going to be influx of sugar because the stomach, the patient has an inability to produce the right insulin levels. But the most important part is gastric outlet obstruction, which is what you see in that figure, is rare. That does not happen with gastroparesis. Now, if it does, it's quite telling that it's not this condition.
Okay, so there were 3 other possible diagnoses before they arrived on the final one. And it's important to note that there are 4 layers to the stomach lining, the mucosa, the submucosa, the muscularis propria, and the serosa. And the neurological control center for most gastric emptying is called the myenteric plexus, and that's embedded within the muscularis propria layer. So because of that, they decided that most likely whatever is causing this has something to do with that specific layer as opposed to the others. So with that being said, the first one was lymphoma, gastric lymphoma. This was considered because of the gastric wall thickening that's very common in these patients. However, it was pretty quickly ruled out because, one, in patients with gastric lymphomas, gastric outlet obstruction is incredibly rare, but also there was no palpable lymphadenopathy upon examination, like I said before. The second possible diagnosis was eosinophilic gastroenteritis, which is basically an inflammatory disease. Eosinophils are disease-fighting white blood cells, and basically a buildup of that can cause inflammation and rigidity in the stomach. This was ultimately ruled out because mucosal diseases in the muscularis propria layer don't pertain to that specific system. They pertain to the peripheral eosinophilic system, which is completely separate. And then the third one, third potential diagnosis that was ultimately ruled out was sarcoidosis, which is another inflammatory disease where basically, again, the immune system basically overreacts and it builds up these clusters of white blood cells called granulomas. This is again typical because of gastric wall thickening, which is common in all of them, but and also, as we said before, hypodensities on the liver, hepatic hypodensities. Those would be the granulomas. But this is typically onset in patients aged 20 to 50, and our patient was 72, so it was ultimately ruled out for that reason.
Alright, so in the end they decided to diagnose him with gastroadenocarcinoma, which is just a very aggressive form of cancer in the stomach. This type of cancer causes a hypertrophy, or basically where these cells start to proliferate like crazy. And this leads to a buildup of a tumor that kind of resembles gastric wall thickening. And this actually leads to all the symptoms that we previously noted, starting with gastric accommodation. As these cells start to proliferate and take up more space in the stomach, you have less space to put in food, and therefore that reservoir that you need to not increase the pressure is no longer there. And any food that comes in will increase the pressure, lead to early satiation, and you're full quite easily. And then also, if it gets to a point where it's so chronic and near the atrium or near the duodenum, this can lead to that complete closure of that hole leading to the intestines, and that's what leads to that gastric outlet obstruction. And as we saw in the patient. And the last thing is, if it's near the if that infiltrative cancer builds up near the fibers of the stomach that are responsible to prevent the acid, well then you'll have the acid reflux that he experiences. And in this case, because he had all of them, his condition was quite poor. And as just a quick summary, like gastric adenocarcinoma has all these 5 symptoms. And the reason why they were having such a hard time diagnosing his condition was because all these conditions are quite the same as gastroparesis. Gastroadenocarcinoma mimics and completely has all the same symptoms. The key distinction here being this part right here, where gastric adenocarcinoma has a gastric outlet obstruction, whereas gastroparesis does not. The part about like the prokinetic treatments basically means like you would have a certain medication to allow like faster flow of food through the stomach, and that would typically help patients with gastroparesis, but it doesn't help you if your outlet is completely blocked, which is why it's ineffective for adenocarcinoma.
Okay. So for diagnostic testing, what you see in the photos or the images is the top one is taken with an endoscope, upper endoscopic evaluation, and that shows grade C reflux esophagitis in the lower esophagus. So that's graded on a scale of A through D, D being the worst. So this is pretty severe. The bottom image is an endoscopic ultrasound, and that showed scattered wall thickening throughout both the upper and the lower esophagus, also into the stomach, in both the muscularis propria layer, as we talked about before, but also the deep mucosa and the submucosa. And due to how like suspicious all this wall thickening and some of the things found upon imaging was, a fine needle biopsy was performed.
You can go first.
So this is a imaging of the specimen from the biopsy. So in panel C, you basically see a zoomed in version of the specimen with poorly differentiated adenocarcinoma cells. And in panel D, it's slightly zoomed out, and you see the serosa, how it extends into the serosa and subserosa as well.
So yeah, as Rifka said, they did a biopsy. They found poorly differentiated tumor cells, which basically just means the cancer is like spreading. It's quite aggressive. This is the worst case it can be. This is the reason why they diagnosed him with stage 4, which means it's quite infiltrated into the stomach. They had quite a lot of different medications they could have tried. They could have tried like checkpoint inhibitors, etc., but none of those really aligned with what type of cancer he had. So they ultimately decided to go with a very standard Folfox assigned like treatment. For his condition, like I was quite astonished when I saw this. It has quite a high response rate. So. And they also were quite hesitant. Like for stage 4, like surgery doesn't seem like a good option. Most of the time it's like completely ruled out. Like why make the patient suffer more pain? But in his case, they saw that the surgery would help him feel better and be able to enjoy life without like the acid reflux, etc., etc. And they ultimately decided for a palliative distal. If you can click Rifka. What this is palliative just means they're not attempting to cure it, they're just trying to minimize what symptoms he's experiencing. Distal means they remove that, if you see in that second stomach right there, they remove the lower part of the stomach and they bypass the duodenum by connecting the jejunum to the bottom part of the stomach, and that's why it's called the gastrojejunostomy, and it's a Billroth too. At this point, they staged them with YP, meaning that they staged them stage 4, T4A, which means the cancer started spreading to the walls of the stomach, and no, meaning no lymphadenopathy, which means the cancer hasn't spread to the lymph nodes, but it is spreading. Ultimately, surprisingly, to everyone's dismay, the surgery 100% helped with his symptoms. He could now experience life in a better way. He didn't have all those symptoms after eating. He can enjoy eating, exercise, etc. And even after 3 months of treatment, he no longer had any signs of the cancer. It was all gone. And it's been 18 months, and he doesn't have any signs of the gastroadenocarcinoma. So quite an impressive tale.
Whoa.